Welcome to Washington Hospital Today, the program dedicated to sharing timely information about the community hospital that's been taking care of Washington Township Healthcare District residents since it opened in 1958. Washington Hospital Today is provided for the sole purpose of informing residents about healthcare topics and issues that have been covered during community forums, free health and wellness classes, or as part of educational sessions held during the district's open board meetings. This program is one more way that Washington Hospital helps empower you, the residents of the district, by providing information needed to make informed decisions about your health.
Sandra Mertesdorf. Sandra has been a registered nurse at Washington Hospital for 20 years. Sandra joined the hospital diabetes education program in 2005. She became a certified diabetes educator in 2008 and is a member of the American Association of Diabetes Educators. Dr. Khalid Beg practices family medicine and is on the staff at Washington Hospital. Dr. Beg attended medical school at Osmania Medical College in India. He conducted his internship at Albert Einstein University in New York and his residency at the Catholic Medical Center in New York. Dr. Beg is board certified in family practice.
So we're going to do a little bit different tonight. I've known Dr. Beg for quite a long time, and we've decided to kind of shake it up a little bit and go back and forth and discuss some of these things in relation to getting your diabetes in control. So we will be going back and forth. So on the slides, what is diabetes? Okay, just basically, this is as a review. When diabetes happens, your body's not getting enough energy like it should. Okay, you're not getting the energy to be able to move your muscles, to be able to think clearly, for your heart to get the heart muscle to beat properly, because the sugar's staying high in the blood. That energy comes from the food you eat. The food you eat, meaning the starches and the sugars. You use protein and fat for other things, but the starches and sugars that you eat are what provides your body energy. Okay, and that sugar, when you have diabetes, is staying in the blood. A lot of it's staying in the blood, and it's not getting moved to the cells that need energy to do their functions in your body. Okay? High blood sugar is called glucose, okay? It's a form of sugar that your body converts every starch and every sugar that you eat, and then it converts it to a form of sugar it can use. And that happens rather quickly. The conversion happens rather quickly. And that sugar is called glucose. So you'll hear the term blood glucose. That means blood sugar, okay? So, but it's the form of sugar that the body uses. So all the starches and all the foods that you eat with sugar in them are converted to glucose before the body can use it for energy. Family history is a risk factor. If you're a woman and had a baby that weighs more than 9 pounds, that's a risk factor. Ethnicity. Certain ethnic backgrounds have a higher incidence. American Indians probably the highest. Hispanics higher. African American higher. But I will tell you, no group is safe from having diabetes. It has increased in every group, every ethnicity, just about every country. It is a huge explosion. When I first became a nurse, I hardly ever saw anybody under 65 with type 2 diabetes. We are seeing children, teenagers, and the highest incidence of diabetes right now, the biggest increase is age 30 to 39 with type 2 diabetes. I never saw anybody that age 30 years ago with diabetes at all. So people are getting it sooner. And there are a lot of factors that are causing this. Lifestyle, like I told you, background too, but lifestyle, fast food, inactivity, okay? So those things are not helping. It's often seen with high blood pressure, high blood sugar, high cholesterol, okay? With smoking, if you do one thing, if you're a smoker and you do one thing to help your diabetes today, think about getting into a plan to help you quit smoking. Okay? The incidence of heart attack and stroke is much higher in people with diabetes. So that's something to think about. And we do have programs here, and I have information on programs that are also online that will help people stop smoking. It's often seen over age 45, but the biggest increase right now, percentage-wise, is in the age group 30 to 39. Lifelong condition. Okay? Once you get it, it doesn't go away. We don't have a cure for it yet. But it can be controlled, and that's what we're here to talk to you about today. Okay. All right, so what I talked about inactivity, high blood pressure, high cholesterol, weight gain. What does weight do? And how does that work against you to control your diabetes? Is if you have excess weight, that creates resistance to your insulin, the hormone that's made in your pancreas that helps to regulate the blood sugar. And your body is more resistant to it when you have excess weight. So your pancreas has to work harder to try and control the sugar then. And over time, it's wearing that pancreas out. And some of those cells are not able to survive that make the insulin. So you start making less and less insulin. And some of that insulin no longer is able to work as well as it used to. So even losing 5 pounds can make a big difference in your control of diabetes. And it's a reasonable goal for some people. I hear people, they say, well, I'm going to lose 25 pounds. That's not a reasonable goal because they set themselves up for failure. Think of something reasonable, go for it, lose a little weight. It will help improve your diabetes control. And you'll feel better all around. Not to go into this for long, but I wanted the slide to be in your packet. This talks about the symptoms for type 2 diabetes and also type 1 because there are different kinds of diabetes. They all have high sugar, but the cause for them is different. In type 2 diabetes, which is the most common kind of diabetes, these are the main symptoms that you see. Type 2 diabetes, you're making insulin. You're not making as much, and some of it's not working as well. It's usually both of those things. So people, the average person could have type 2 diabetes for 5 to 7 years and not know it because it slowly comes on as the pancreas continues to struggle and try to make enough insulin and handle bringing the sugars down. So people don't realize they're more tired. They think they're older, but in fact, it's diabetes that's making them more tired. They'll get thirsty and they'll urinate more because their kidneys are trying to get rid of the excess sugar, but they can't keep that up. Okay? They can't get rid of the excess sugar. And you will be urinating more and you'll be thirsty because now you're losing water in the urine, so you get more thirsty. You get dehydrated. Most of the people that I have that come in, they've been very fatigued. Now they've started to they notice they're urinating more, they're thirsty, they get tested for diabetes by their doctor. It's not uncommon like that. It's not something that usually comes on very fast. Type 1 diabetes, different kind of diabetes. In that kind of diabetes, it's an autoimmune condition. Something goes wrong. The body thinks that the pancreas, the insulin, there's something wrong with it. It's foreign, and it kills off all the cells that make the insulin. And they don't make insulin anymore, and they need insulin from the beginning to live. So it's very different. Knowing what kinds of diabetes and the differences, you talk to somebody and they say, well, I know somebody who has diabetes. Well, you say, what kind of diabetes do they have? Because you need to be speaking apples and apples. What kind? What kind of diabetes? And people are always well-meaning, but they may not have the most accurate information. So that's one of the reasons for this program. Dry, itchy skin is very common for people. They have dry, itchy skin. They think their lotion's not working anymore. But in fact, when you have diabetes, your skin can be drier. So let's see. Numbness and tingling could be early signs of nerve damage. I have had people say, I can't feel my feet very well anymore. My feet are burning. Those can be early signs of nerve damage related to diabetes, and they didn't even know they had diabetes. But they had a sign of the nerve damage, and they went and saw their doctor. Okay. Diagnosing diabetes, fasting test 126 or higher. That fasting means you went all night without eating. Okay? You can have water, but not eating any food or any other thing than water. Somebody with pre-diabetes, there's an in-between place called pre-diabetes. It's not normal, which would be a fasting of 60 to 100. Somebody without diabetes, a normal blood sugar is about 60 to 100. But it's also not a diagnosis of diabetes yet. So we call that pre-diabetes. It used to be called borderline diabetes. We don't call it borderline anymore because it was a misleading term. Thinking, okay, I'm fine. I don't have diabetes. I just got a touch of diabetes. Well, that touch, if you don't do anything about the fact that your pancreas is starting to struggle and start looking at how you can control the food and how you can be more active, you will most probably have diabetes in the near future, because the sign of having a blood sugar fasting over 100 to 125 is a sign that your pancreas is starting to struggle and it needs to have something done. An A1C now, it can be diagnostic of diabetes. A normal A1C is usually less than 6, usually somewhere between 4.5 and 5.8. Somebody with diabetes in general will be over 6 and above. But it has to be done on 2 separate verified tests, not just one as a diagnosis. It has to be done twice. This is pretty new. In the pre-diabetic range, you can see the A1C is not normal. It can be as high as 6.4. Okay? But at 6.5 on 2 separate tests, validated, that's a diagnosis of diabetes now also. Somebody with, when it says random test, that means you already ate. And these are blood sugars that are in comparison. If you already ate, you weren't fasting. Okay. All right.
Just to rewind back just a little bit, me and Sandy have worked together for many years, and I worked with Sandy on the floor when Sandy was the big boss, and she still is the big boss at home. So I want to make sure you know that. But it's one of the most important things for me is to be able to come together and present a very big topic like this. And diabetes is very challenging, and what I just want to remind everybody is we know it's a very significant disease, but at the same time, we have a lot of knowledge and information to tackle it very well. So, if you remember in the olden days, people used to be very afraid of insulin because they would think insulin is like the end all and they're in big trouble. Nowadays, what we do is not only do we have many different types of insulin, but we know how to use them very effectively. We'll talk about that as we go along, but I just want to make sure that we understand that diabetes is a very protein disease. In fact, I have a funny story to share. One of my senior colleagues who since has passed away, he went to med school in Vienna, Austria. And he said in those days, Vienna was a very syphilized society. In other words, there was a lot of syphilis in Vienna in those days. Okay, so
disease syphilis.
Syphilis. So they used to call it syphilized society. Well, the reason syphilis was very important in those days was syphilis would attack from the brain down to the leg. Okay, it had its protein manifestations, and luckily we are way behind on the incidence of syphilis, but we are way ahead, as Sandy has said, in the incidence of diabetes. And to give us a few numbers very briefly, the annual incidence in the United States for diabetes is 8.2%. What that means is if you add 100,000 people every month, 8.2% in 1 year will develop diabetes. That's a lot. That's a lot. Okay, number one. Number two is our country, as you know, spends billions of dollars on healthcare. And if you're spending $300 billion, it's more than that. 14% goes to diabetes-related conditions. That's a lot of money. Well, it's not the money we're concerned about. It's the disease we're concerned about. So that's the important point here. And as Sandy said, I just want to reiterate that the lifetime risk of a person who's a male in the United States of developing diabetes is 33%. That's a lot. That's a lot. The chance that a lady will develop breast cancer in her lifetime in the United States is less than one by 4. So there's a big difference here, as you can see here. So just want us to understand that. And that's for males. Men, 33%. And for women, do you think it's less or more? It's more, 39%. I don't know why women are being targeted all the time, but I'm kidding. But it's very dangerous, very serious, okay? And we need to acknowledge that. We need to work on it. We need to be very careful how we diagnose this condition. And if you look at Caucasian populations, it's 8.4, Hispanics 8.2, Afro-American 11.4, and as Sandy said, Native Americans, Pima Indians, for example, it's 28%. That's very high. Now, what I have learned from diabetes is since I was a kid, my dad used to do hemoglobin A1C when I was a small kid. I remember that. So Sandy's already touched on hemoglobin A1C. I want to know how many of us here have diabetes? Okay, a fair number. Okay, how many people know what hemoglobin A1C is? Okay, that is awfully low. So please, one of the most important things which me and Sandy can do for you is to give you some important driving lessons, how to drive your diabetes better and not let it crash you. Okay, that's really what it's about. Now, hemoglobin A1C is one of the most important tests in diabetes, in my opinion. It gives us the average blood sugar for the past 3 months. So if I do my hemoglobin A1C today, it tells me what my average blood sugar is for the past 3 months. Now, that is a great gift from God. It's a window for my past so I can get better for my future. That's the way to look at hemoglobin A1C. So for all of us who don't have diabetes, for example, and I want to use this as a very aggressive example, we know from the data I've presented, if I'm a male, I have a 33% chance of developing diabetes. If I'm a woman, 39%. But what do I do? Well, I need to do something for myself. I need to make sure my doctor not only checks me yearly, but does a hemoglobin A1C. I'm a very strong proponent of hemoglobin. In fact, if I see a child who's a little bit more than what they should be, they say overweight but not obese, okay, I do a hemoglobin A1C. And guess what? I pick up pre-diabetes, as Sandy has shown, pre-diabetes in 1/3 of my kids. That's horribly high. And that's the population which is really going to bloat the figures for diabetes in our country. So we need to be very careful. So hemoglobin A1C, my dear ladies and gentlemen, please, it's your average blood sugar for the past 3 months, and this is what drives it. Okay, now I have to quote this study called the UKPDS study. Now, we don't want to think about independence, but we want to think about what the British did with diabetes, okay? And they've done a great job. They've done a great job. What they did was they did a very simple study in which they look at the hemoglobin A1C and what complications did people have for every 1% rise, okay? And what they showed was every 1%. So somebody's supposed to be 7% on their hemoglobin A1C, they're 8%. Their chance of having complications, heart attack, stroke, visual problems, you name it, everything associated, was more than 12%. 12%. That is unacceptable. So we want to make sure that we are below 7%. And there's one thing I tell a lot of my patients, and I'm very aggressive about this. And what I tell them is, even if you have 7%, do not be satisfied with that. First, reach your goal. But if you reach 7%, do not be satisfied with that. Go down more. I'm not asking us to go down to 6%, but I'm definitely asking us to go down to 6.5. So please remember that. So, get ahead on your success. That is where we prevent complications from diabetes. It's very, very critical. So going forward, what we wanted to talk about was our next step, which is what is our goal of treatment? Okay, we already talked about it. So if you're going to do a hemoglobin A1C, we want to make sure our hemoglobin A1C is below, my dear friends. I'd love to, let me put it this way. When I look at a hemoglobin A1C, am I happy seeing 6.9 or 7? I'll take 6.9. Okay, so the lower the better. Okay, so and we don't want to stop there. We want to get ahead on that. Now, hemoglobin A1C is a broad 50,000 foot view of what's happening down below, but we need more control as we go along. So we're going to talk about how we can do better control as we go along on a daily or weekly basis with blood sugar testing. And the second important thing is there is a nexus. So it's called the axis of evil. I'm kidding. I think it is, if you look at politics, especially now. So the axis of evil to me is blood sugar, high cholesterol, and high blood pressure. There's a lot of research going on in the United States, which is the greatest country in the world for research. I want you to know that. It's the greatest country in the world. We put out so much research, 15 other countries in the world can't even come together and do it. And what this research is going on is to try to find out what is the exact link between these three. We know very well that if all three of them are not under control, people have a problem. So we want to make sure we have all those goals in place to make sure that we are successful in our overall treatment. And we'll go over more details as the slides go on for blood pressure and cholesterol. But there's definitely information there which is very important for all of us on that basis. And balance self-care in your life. So I'm sure Sandy can tell us more about that.
Complication prevention is the name of the game when it comes to diabetes, because improving, getting your sugars in control, and it'll help you feel better, but it's going to prevent complications. And a lot of them are preventable. Okay? A lot of them are preventable, and it's very much in your ballpark to be able to do this. So we use what we call the AADE7, which is the Society for Diabetes Educators. These are the things that help control your diabetes. These are the areas to focus on. We call them the keys to self-management. Healthy eating, being active. Being active, when you're moving sugars from the blood into the muscles. It helps keep the blood sugar at a better place, and you get the energy you need. Monitoring. You're real-time monitoring at home. You're going to get your A1C every 3 to 4 months, and that's going to tell you your overall average control. But it's not going to tell you whether your fasting blood sugars are in control in the morning. And they may not be. The only way you're going to know is if you do some at home, real-time tests. Because in an A1C, all of those are averaged together every moment of the day while you're sleeping, what your blood sugar is. When you're fasting in the morning, it takes into account all your blood sugars. You need to know where your problem areas are, because if you know where your problem areas are, guess what? You can do things to improve your blood sugar. If you know that you're eating a certain food, you're eating 2 cups of rice at dinner, which is actually 6 carbohydrate servings, which is actually 90 grams of carbohydrate. It's a lot. And you check 2 hours after you eat the meal, and you see that your blood sugar was 115 before you ate and 290 after you ate. You know the after number. In our program, we use less than 160 2 hours after a meal as the goal. It's over 160. You probably overate the carbohydrates. You can go back and look at what you ate, rebalance it so you can get in better control. So there's a lot of things that you can do in the morning. Your fastings are high in the morning. What might have caused that? I ate a lot of carbohydrates at dinner, too many. I ate a huge snack just before I went to bed. I'm sick. Sickness, illness can raise your sugars too. I've been sick, I've had a fever for the last 3 days and they're high. So there's a lot of problem solving where you see the arrows up and down. You can problem solve things and try to fine tune your control by getting real-time numbers. Healthy coping, when you're stressed, your blood sugars can be higher. Just when you're sick, it is a stress on the body. Fevers, diarrhea, vomiting, which is dehydrating, those things can make your sugars higher. So, you know, taking a walk after dinner, it reduces stress, it helps move the blood sugars to your muscles to use, and it leaves your blood sugar in a better place. A nice idea. There are a lot of things that you can do. You can pick any one of these and get improvement, and they can add up. They can be cumulative and get you into a better place. Dr. Begg talked about the risks. Eye disease is one of them. That's why the eye is there. But all kinds of complications. The eyes can be affected. There's a condition called retinopathy, which in the back of the eye, the doctor can dilate the pupil, look in there with a flashlight, and see if those blood vessels in the back of the eye are healthy. Because with sugars high over time, they can leak blood, and it can cause vision loss. It's the #1 leading cause of vision loss age 21 to 74. 21 to 74. So, and it is preventable, okay? And for people with diabetes, the recommendation is to see your eye doctor for that test at least once a year, okay? Or more often if the doctor wants to see you more often. Adding humor. Humor does what for your stress level? Does it increase your stress level? It brings it down. So I've talked about the blow 'em up, CIA movies, where I'm stressed when I watch those things. So I like a funny movie or something that's going to be uplifting. Just, I mean, you might like them, but it probably makes you more stressed. You release adrenaline. But, you know, find something humorous to laugh about. Watch a funny movie. Go out with a friend. Do things that you enjoy that are uplifting for you. Taking your medication, I can't tell you enough. Dr. Begg sees it and I see it. We have people that come to our diabetes program. Now I've been doing that for, I think, 7 years. I've seen a lot of patients in classes, seeing them individually. A lot of people do not know how their medications work. They don't know how they work. They don't know when to take them. They don't know some of the precautions that they should know about them and the side effects. Those are 4 things you need to know when you're taking any medicine. When you're taking your diabetes medicines and you want to get the best control out of it, how are they working? What am I expecting and what do I need to look for that could be a problem related to my medicine? So ask your doctors when you get them ordered. And you also go to the pharmacy and pick up that new medicine, and you can, by law, have a consult with the pharmacist face-to-face. Just say, I want to consult with the pharmacist. They'll have you come over to the side. Pharmacist comes out and talks to you. You can ask them all kinds of things. And if it's a pharmacy you use, they got your medication profile. They can make sure that everything looks like it all goes together. So ask for it. And those papers that they give to you about the drug that are in the little bag when you take your pills home, read them. Okay, read them, because there's really important information on there. People have missed all kinds of things that I've seen. Okay, but when we sit down with them, it's a different venue and a different way to learn, and it is easier to learn that way than read a paper. And we are often very much correcting people as how they're taking their medications when they are, and we have recognized side effects before, and the patient really didn't have any idea. So very important. Blood pressure, A1C, cholesterol. Everybody knows the different kinds of cholesterol. The bad one, the LDL. Okay, you want that less than 100. Okay, the HDL, I call it the happy cholesterol. You want that one for men over 40. This is the newer recommendations, and for women over 50. And they're both called cholesterol. But one of them's not good. It lets all that bad plaque and stuff stick to the insides of your blood vessels. and the HDL goes back and collects it and recycles it. So you don't end up with plaques in your arteries that stay.
If you look at angiograms of people who have diabetes and who don't have diabetes, there's a big difference. In general, when a person has diabetes, it affects the blood vessels, high blood sugars. So that's the basic pathogenetic dysfunction. So it causes more diffuse narrowing. So as Sandy said, I just want to make sure we reiterate the point that I would urge you to make sure with your physician that your LDL is below 100 and your HDL is as high as possible. So we want to be happy and have some humor. And also the triglycerides. There's a lot of body of evidence right now from research which shows that in a lot of people with diabetes, the triglycerides are elevated and we cannot ignore them. So all these three, the last three are very, very important in avoiding heart disease down the line. The second point I didn't want to miss was, with diabetes, I have sometimes people telling me, I'm seeing fine, why do I need to see an eye doctor? And as Sandy said, if there's microscopic changes, the only way to find out is by having a dilated eye exam, as Sandy said. So it makes a lot of sense. So even if I'm seeing well, the only way to make sure that I continue to see well is by having a dilated eye exam once a year.
Okay, and salt. Limit salt. It's not good for your blood pressure. All right. Smoking we talked about. Limit alcohol. Reduce your cholesterol. Take medications as directed. Okay? Know what the side effects. Try to get more active. If you went for a 10-minute walk and you haven't been doing that for the last 5 weeks, that's a win. And the more you do it, the better you're going to feel. And once you get up out of the chair and put the remote down, you're more likely to enjoy doing that. We don't even move now. We have remotes. We're sitting there pressing that. We're not even getting up to do the channels anymore. Limiting the alcohol is very important. Everybody's plan is pretty much the same. Activity and regulating the food, learning how to do that, are two of the commonalities in treatment for diabetes. Some people will start with food and activity to focus on. Food and activity plus diabetes pills. Might be food and activity plus diabetes medicines and injectables like insulin or Byetta. And then it may be just food and activity and insulin. So everybody's method for managing their diabetes may be a little bit different. But the thing that's common is food and activity is important for everybody who has diabetes. Everybody. Safety of the medications, like you were talking about, make sure that you're safe. Make sure you got the right medication when you go home. Know when to take it. Know what the side effects are. Discuss changes with your doctor. Handling and storage is big. Some medicines need to be refrigerated. Okay? Insulins are when they come home, they should go in the refrigerator. You don't want them to freeze because they may not work very well anymore. And if they get more than 86 degrees and it's still warm weather, it can make the insulin less effective. Okay? And a lot of medications, even though there's some left in it, a lot of the insulins, in fact, all of the insulins, have a date where you're not to use them, even if there's some left. NPH, Humalog, Novolog, after 28 days, you're to discard them, even if there's some left, because they may not work as well.
The two things I really want to add here is, one is a lot of physicians now are getting savvy. They have electronic medical records. What I would urge you to do is do two things. One is the old thing, which is write down the list of questions you have for your doctor. Please, please do that. Make them work for you, number one. Even though I'm trying to get out of it.
Yes.
The number two thing, which is very important, is it's for your own safety, which is of paramount importance, that we have a list of the current medications you're taking. and make sure you go over them with either the doctor's nurse or the doctor himself or herself. And this will really, really make that condition far more efficient. And if it's not, you'll see it, that it's not working. So I deeply request you to do this at every visit. It may look boring. Sometimes people have 12 different medications, and I have a person who has 24 medications. But no matter how many we have, it's incumbent upon us to make sure that every medication is being taken in the dose it was supposed to be, and it's doing its job.
So, like you mentioned, there are a group of medicines called the sulfonylureas, long name. There are 3 medications in that group, and they all start with G: glipizide, glimepiride, and glyburide. And all of those medicines in the sulfonylurea group will help you secrete more insulin from your pancreas. So they are taken before you eat, okay, usually. And then you eat afterward. Your blood sugar goes up because you're eating, but that medication has started to work. And instead of your blood sugar being this high, the medication is working as you digest the food, so it only gets this high. So it reduces your risk for complications because you're in better control. Knowing how to take that is important, because if you take it an hour before you eat, it's going to be lowering your sugar, but you haven't eaten yet. So it can lower your sugar too much. Okay? If you take it after you eat, you've already started to digest your food, and your sugar has gone up more, and the medication is just starting to work. If you had taken it just before you ate, 15 minutes to 20 minutes before you eat, it's going to be working as soon as you put that, start to work as soon as you put the food in. Some people forget it, and so they forget to take it, and they will take it right after they eat because they're not sure if they're going to eat all the carbohydrates. So they'll take it right after they eat. But you want to try to get the best glucose lowering effect of the drug. You take it before you eat, and you make sure that you eat the regulated amount of carbohydrates that are recommended for you to eat, because if you don't eat the carbohydrates, you run the risk of a low blood sugar, and we'll talk about that in a minute. The next group, metformin, very common drug, is used as a first-line drug for a lot of people with diabetes, as long as there's some reason that it's not indicated as far as other medical conditions that they may have. It will help to stop the liver from releasing little bundles of sugar that it has stored, which is great for a rainy day when you're not diabetic. But the backup mechanism doesn't work for people who have diabetes, and you can actually get more sugar put in the blood even if your sugar is too high already. So the metformin stops those little bundles of sugar from getting absorbed into the blood from the liver, and in that way it helps make sure that the blood sugar is not as high. Okay? It isn't like the sulfonylurea group that makes you secrete more insulin. It's working on another part of the body to control the blood sugar. It's usually taken once or twice a day most of the time. The maximum dose is about 2,500 milligrams. It has some potential, it has some precautions and some side effects that are there. The most common side effect is gas, bloating, and diarrhea. People start to take it after they've taken it a few times. If they take it with the food or right after they eat, those symptoms are usually less and will subside. Every once in a while somebody can't tolerate it that we've had, but taking with the food has really helped a lot of people. It's a big pill too, so big pills. They are in generic form, which is really great because it's a more affordable drug. Precautions, you need to know if you are having surgery that they usually hold the metformin. The doctor will tell you when to hold it and when it can be restarted. And the same thing when you have a dye injected in your vein, like for a CAT scan, so they can visualize the pictures better. They usually will hold the metformin if you're having a dye study and they will tell you when to start it again. Okay? People who have drink a lot of alcohol, particularly people who are binge drinkers, meaning they drink a lot of alcohol at one time, they may not drink every day, can be at risk for a side effect called lactic acidosis. That escaped me. It's not real common, but it can happen. So, if you are drinking alcohol, make sure you talk to those precautions with your doctor. But specifically with binge drinkers, it can happen, it can get muscle pain, weakness, it could be very dangerous. So knowing a lot of these things is important. It can take 2 weeks to take full effect. I have people that say I took it for 2 days, it didn't do anything for my blood sugar. It can take 2 weeks to take full effect, okay? So you need to wait to see if it works. And how are you going to know if it works? You're going to check some blood sugars at home, right? You're going to see it improving. Another group of medicines help the pancreas release more insulin. I'm not seeing them as much as I used to, but the 2 drugs in this category are Starlix and Prandin, taken just before the meal. If you are skipping the meal, you don't take the medicine. The same with glyburide, glipizide, and glimepiride. If you're not eating the meal, you don't take the medicine, or you'll get a low sugar, too low, where you can get shaky and sweaty and feel dizzy like you're going to faint. Actose, and it's become more common. It's a newer medicine out in the market. This drug helps this group of drugs. There were 2. One was taken off the market, Avandia. It helps you to be more sensitive to your own insulin, the insulin that you do have in that way. It's usually taken once a day, same time every day, doesn't matter with or without food, because it works in a different way than the sulfonylurea group does. Risks, I have seen people that have had new swelling that they didn't have before they took it. So if you are taking it, make sure that you report to your doctor if you have new swelling anywhere in your body. I don't care if it's in your face, your hands, in your legs, new swelling that wasn't there before you took the medication. So it is not available in generic, and it is more expensive than metformin and some of the other drugs. You have to have a good liver to take this medication, so they'll be watching your liver function, lab test to make sure that your liver is healthy. If you have a heart history, this may not be the medication for you. Oh, and it does have an increased risk for bladder cancer. So monitoring that, your doctor will be monitoring that, okay? Knowing those side effects and possible things that could make a difference. Another group of new medicines help the insulin making cells work better. The cells in your body, the beta cells that make the insulin in your pancreas, it helps them work better, okay? The most common one right now is Januvia. It's been out on the market. There are 2 more that are out that work pretty close to the same. Taken once a day, doesn't matter with or without food, but you want to take it once a day. If you have kidney problems, this is not the drug for you. Any kind of kidney disease at all, you have to have good kidneys to take this. If you have a kidney problems, lab tests that are a little high, they may decide to start you on it with a lower dose to see how you do, so a reduced dose. But in general, you have to have pretty healthy kidneys to take this. May increase risk for low blood sugar if you're taking it with other diabetes medicines that work in different ways. So you may be on one medicine, and then you add a second one that works a different way to lower your blood sugar, and the combination of the 2 of them may actually lower your blood sugar even more. So be aware, check your blood sugars when you're trying a new medicine to see what the effect of the second medicine is going to do on you. It may be more than you think it's going to be. So you need to be following up and doing sugars. There's the Gila monster. This is Byetta. It actually comes from, it's an injectable drug taken before you eat. It's to help control your blood sugar. It makes you feel more full. It came from the saliva of the Gila monster. Kind of amazing. The Gila monsters can go a long time without eating. They feel they're very full all the time. But that's where it came from. And there's two newer ones in primarily the same drug group. Victoza, which doesn't need to be taken with the food like Byetta. It can be taken with or without. And Bidurion, which is a once-a-week one. So they're all injectable. Bidurion's pretty new. It hasn't been out of the market very long. They help the pancreas cells work better, slow digestion, so you get better control because your sugar doesn't go up as fast. May help you eat less, nausea, weight loss. You might have some nausea, and you might have some weight gain, okay? And usually the nausea will subside, after you get used to it a little bit. So, and there's different doses, and everybody's a little bit different. The insulins, I'm not going to spend a lot of time on this, but it's the fact that there's different insulins. Some of them are long-acting, like Lantus or Levemir, very long-acting, or an intermediate-acting insulin called NPH. And those are meant to keep your blood sugar lower at night when you're sleeping and not eating, and in between meals when you're not eating, okay, throughout the day. Sometimes they're taking once a day, like Levemir. Sometimes Lantus once a day. You might need to take it twice a day. Usually NPH is once a day or twice a day. And then there's the mealtime or correction insulins. They work very fast. The most common ones are Novolog and Humalog. Okay? The older one, which was a short-acting insulin, not as fast-acting, was regular insulin. Novolog and Humalog you take just before the meal. They start working in 5 to 15 minutes. Very fast. Okay, you take it just before the meal, no delay, and you will get a low sugar if you don't eat after you take it because it starts to work so quickly. And then you get about a peak. It works the most about 1 to 2 hours, and about 3 to 4 hours it's out of your body, which is about time for the next meal. So knowing how they work is very important. All right, rotating sites. Don't stick your insulin in the same spot. The tissue will get hard. If the tissue gets harder because you're poking in the same place, is it going to work as good? It's not going to absorb as good. So you need to rotate sites. The abdomen is as long as it can be given there, is a very common site. It absorbs well from there. It's easy to get to. Stay away from your belly button. Over on the sides, at least an inch away from the last injection. Pinch it up a little bit. You're giving the insulin in the fatty tissue underneath the skin. Insulin does not go in the muscle. Okay? NPH is a cloudy insulin. It has to be mixed before you give it, rolled between your hands. Knowing that's very important so you get the right dose. So the rest of them are clear. And we talked about storage and handling already.
I'd like to add a few points to what Sandy said. One is, if you look at all these medications in these different classes, which Sandy has presented so wonderfully, the one thing I want us all to know is which medications carry the best bang for the buck. That's food for thought. Okay? And that's what Sandy was trying to present. If you look at her lecture, that's the message behind. And I want to make sure we all understand that. And what we want to do is we want to use a combination, and that's best done with your physician, because that was one of the discussions me and Sandy had before this lecture, is how to impart that knowledge to everybody here so you can get the best out of this. And one of the best advice we have is, you can use these wide array of medications for your best advantage. And I would urge you to, now that we've known the mechanism of action and how it should be done, the second thing to do is to discuss with your physician what would work best for you, number one. Number two is you can mix and match. That's the beauty of treating diabetes nowadays. The third is pricing. There are a lot of, because there's a lot of competition, as Sandy presented this, for each class there's a whole host of different medications of the same class. So that's good for us, the consumer. So what happens with that is you can get a better pricing. So you can actually pursue some of the newer medications if they're going to work for you for a better price. So that's one thing I would definitely urge you to discuss. The fourth and not the least is I don't know how many of us use insulin and how many of us use pens versus syringes, but I can tell you something. The pens are a revolution in diabetes. You know, coming from the olden days where, you know, I would have to draw from this horrible syringe, 5 units. It's not a lot of insulin, but it's a lot of effort. And then, if I have some eye condition with my diabetes, well, add to more problems. And I've seen people give themselves the wrong dose just because of the mechanism, not because it was their fault. So I would urge you to consider the fact that we have some phenomenal delivery systems available, and they're painless, literally painless. Today, I taught 11-year-old girl how to use a pen on herself, and that's not easy. So these are very important points I would urge you to consider.
So preventing the complications like I talked about, here they are. Eyes, kidneys, heart, nerves, foot problems due to poor circulation, due to nerve involvement, can affect your feet. People with diabetes can get infections easier. It can be harder to fight an infection once you get it. So you hear all these stories about people who had amputations. Those are preventable. And 50% of them, if you looked at your feet every day, you're going to find something that's wrong before anybody else is. These could be prevented. 50% of them could be prevented, amputations, if you looked at your feet every day. You're going to find something that gums are there because gum infections are more common with diabetes. You need to go see a dentist. Gum infections lead to nasty infections in the rest of the body. So having your gums healthy is very important.
One of the fastest rising complications in the U.S. is kidney disease. If you go to a dialysis center, you're going to see a lot of people who are on dialysis now, not because their kidneys didn't do a good job, but the diabetes was not under control. So the paradigm has shifted from hypertension to diabetes and or hypertension.
All right, glucose monitoring, I already talked about. Benefits, you get immediate feedback as to what's working. Are my fastings okay? Did I check 2 hours after my meal? Am I less than 160? Am I good? Am I not? I'm going to rethink the carbohydrates I had. I had the right amount of carbohydrates. I think I'll take a 15-minute walk after that meal and see how that works for me. Problem solving. Helps you decide what works, what didn't, what changes you need to make. Check after after your biggest meal. You get more bang for your buck. If your biggest meal is usually your biggest problem. And the rule of thumb is to try and fix the fasting first, because if your fastings are already high in the morning, they're going to get higher as you add food in during the day. So focus on one area, and then when you improve at that, focus on something else. And keep working at it to improve your control. The only way you're going to know if the changes work that you did is by looking at blood sugars on a daily basis. The real-time effect of what you've done. Strips, I'm not going to talk about this at any length, but monitors, glucose monitors, there's a lot of them on the market, okay? They're not going to be on the market, and they have to meet certain specifications of reliability to be on the market here in the United States. It gives you real-time information. You have all these supplies. You have strips. You have lancets to poke your finger with. You have control solution to see if your meter is working. If you don't, you can get it at the pharmacy. Have them order it for you. And a lot of the meters companies, if you call the 800 number, which is the customer service help number, if you're ever having a problem with your meters, usually they're 24 hours, 7 day a week customer service. And you can see if they'll send you a bottle of control solution. So if you think you drop your meter and you think it might not be working right, you can use the control solution. You put that on instead of blood. You shake it up and put that on. And then you look at the strip bottle. It says control range on the outside. If you're in those numbers, your meter's working good. If you're not, something's wrong with it. You need to replace it with a new one. It is actually usually the strips. Log your results so you can see your patterns. If you log it in a book, I brought log books for people, so certainly pick one up. I can look at somebody who's given me a logbook that's at an appointment, and I look down at their fastings for the whole week, and I can tell you what kind of control they in because I can see the pattern for the whole fasting for the whole week just by glancing at it right away. I can look at their 2-hour after dinner numbers, and I can see how they're doing and how they're improving because they're right there in print in front of me. It's real-time information. All Lancets aren't created equal. Some of them are thinner and some of them are not. Okay, so finding one that's the most comfortable for you can make your life better. So you don't dread testing yourself as much. Okay.
Yeah, and there's some meters where you can use different sites instead of just the fingers. So it can be on palms or on the thighs. So that's a very easy way of doing it.
It depends on the meter company and what their meter is actually able to do. But you will hear, and I'm glad you brought that up actually, you will hear, I have people say when I do forearm testing, that testing is not good at all times of the day. It's not reliable, not as reliable as the fingers. So you need to know if it's okay to do these sites, when it's okay to do these sites, and for what meters it may be okay. Because for some, they're not reliable at those times, but for other meters that are coming out, they have some more options. For in general, you can check all of your fingers for most of the meters, including your thumb. You don't want to poke the same place all the time because you'll get sore, so you rotate. The fingers in general are probably the most accurate, okay, in general for all of the meters. Insurance coverage drives this. You get the preferred meter, you get better insurance coverage, right? So sometimes you need to go with the the glucose meter that your insurance wants you to use. But a lot of these meter companies have special things, special coupons, and a lot of them want to be very competitive. So they will reduce your copay if you join their Little Promise program or another program. I can name 4 right now that are very competitive with each other and can get your copays down to like $15. So there's some working there you could do to save yourself some money. Sharps disposal, they have to go in a special container by law. The Sharps, the red puncture-proof container. When it's full, you cap it, and then you have to take it to the county site that takes the hazardous materials. You just drive up and give it to them. Now, there's no cost to dispose of it, but you have to buy a new one. If you put them in your trash, it's against the law, and if they find them, they can give you a big fine. Hand lotions can affect your results. We have new research on that. Food on your fingers can affect the results. I said barbecue sauce because it has sugar in it too. But if you've touched the greasy doorknob that somebody else hasn't washed their hands with, and now you got their popcorn grease on your hands, that can affect your. So wash your hands. You want the most accurate test? Wash your hands with warm soapy water before you test. Okay, the warm water brings the blood to the fingers, so you get a good poke for first time, and you get a more reliable test result. That's what's recommended right now. If your hands are really, really dirty, and you have to use alcohol or something like that because you can't wash, the alcohol has to be dry before you poke, or you can get a wrong result too. But warm soapy water is the recommended. Glucose testing times, if you're sick, check more often. Your sugars can run higher. If you're running high, call the doctor. You have fever, you have flu, diarrhea, vomiting, call your doctor. You've got high numbers, you need to get intervention there. Okay, get back on track. These are the goals that we use in our program, okay? But follow the goals that your doctor has given you. These are the goals that we use in our program unless the doctor has specified different goals. They know their patients. We use 70 to 120 fasting and before meals, and we use less than 160 2 hours after you started eating a meal. Not from the end of the meal, from the time you took the first bite, 2 hours after. These are the goals. Not everybody may be able to get to these goals, but if they're working toward them and improving, you've got better control. You have less risk for complications. You're making things better for yourself down the road. Looking at patterns is what we're looking at. Okay, I'm looking at the fastings. I'm looking at the 2-hour after meal numbers. I'm looking at where they're coming in before the meal. Learn what affects your body. Consider targeting one area. If you don't know if your fastings are in goal, let's look at them. Do some tests. If you're not willing to do tests every day, do a fasting test every other day. And you'll get a good picture in a couple of weeks of where your fastings are. And you're going to know. And you can try something that's different to help them improve. Know when your medications peak. Know when you need to take them and what the precautions are. Do they go with the meal? They don't go with the meal. If I don't eat after I take this medication, I can get low. If I took my insulin and I don't eat, I took my mealtime insulin and I don't eat, I'm going to get low. You have to know all of these things.
You know, I totally agree with Sandy's advice. I have seen many people whose fasting blood sugars were immaculate, excellent. You know, they're always below 120, 130. But when you do their hemoglobin A1C, it's 8 to 9%. And so I started to think that the lab was doing a goofy job. And once we started doing their 2 hours after a meal, it was very obvious they were shooting high. And as Sandy said, you know, when it shoots high, you want to take a medication that's going to bring it down. That's exactly what is needed. So it makes a lot of sense keeping a track or a tab on the post-meal blood sugars.
Hypoglycemia, hypo, that means low. Signs, and they're in your packet. Shaky, sweaty, out of energy, feeling very hungry, dizzy. You're not thinking clearly when your brain cells aren't getting enough sugar because your blood sugar's low. So you shouldn't be driving if your blood sugar's low. You should pull over, have a snack, carry fast-acting sugar with you, whether it's 6 or 7 Lifesavers or a juice box or 3 to 4 glucose tablets, 15 grams of fast-acting sugar. There's examples in your packet of different things that are 15 grams. Check your blood sugar after 15 minutes. If you're above 70, great. Go ahead and have your snack, or if your meals do, have that. If it's not above 70, you treat yourself again. And then you wait another 15 minutes and check. If you're still not above 70, you take some more fast-acting sugar and you call 911 or your doctor, okay? Something's wrong. You may have taken the wrong amount of insulin. You may have not eaten after you took one of your medicines that you needed to, but you need help, okay? And the blood sugar, you know, if the blood sugar gets low enough, you can pass out, and that can be dangerous. So you want to get it up as fast as you can. Carry something with you in your purse or your pocket that's portable, like the Lifesavers or glucose tablets, so you always have it. And I tell people have it at their bedside, because if you're getting shaky and sweaty and you wake up with a low, and you got to go downstairs to the refrigerator to get the juice, that's a long trip when you're not feeling good. So have it at your bedside so you're already prepared. Doesn't happen very often. I did have somebody in class recently after I talked about hypoglycemia that came back to the next class, and she said it was really scary. She went on, she did more exercise than normal, but she had a snack with her, and she had fast-acting sugar, and she treated it, and she was so happy that she knew what to do, even though it was a scary situation because it kind of makes you feel scared. So she knew what to do. So you need to treat them, and less than 70 is too low, okay? Less than 70 is too low. So even if you're not having symptoms and your blood sugar is less than 70, you treat it. So you need to get it up so you stay safe. Hyperglycemia, over 200. That's a definition of hyperglycemia. And you may be 300 or 400, then you're hyper. You're way higher than where it should be. If you leave it untreated, it puts you at risk for complications. It's harder to fight infection if you have high sugars, okay? Can cause dehydration, and it can cause something called ketosis, which when your body's not getting the energy that it's supposed to, it's staying in the blood, but it's not getting into the cells, the body will go to breaking down fat for energy. And that is ketosis. And that fat byproduct is an acid called keto acid. And when that builds up in your system, it can be very toxic to you. So you're not meant to go around with high sugars. Your body's going to go to stores of fat to try and provide the energy temporarily. So make sure if you have high sugars that they get addressed. You're sick, get seen. All right, blood sugar above 200, you can feel very thirsty when you're high, just like when you first got diagnosed with diabetes maybe. You'd be thirsty, you're dehydrated, you're tired, blurred vision, headache is common, abdominal pain, loss of consciousness. If you get high enough, you can be in the emergency room and need help. And I will tell you, people who get sick that have type 2 diabetes, their blood sugars go up, they wait too long to get help at the hospital. They wait too long to call their doctor, and they end up at the hospital with 600 and 700 blood sugars. This is dangerous stuff, okay? This is really dangerous. Where it could have been intervened, they could have called their doctor, tell me I have high blood sugars. The doctor sees you, you get an antibiotic prescribed, you're drinking plenty of fluids, you're vomiting, but you can't keep much food down, but you're still sipping on carbohydrates to keep your energy level. There's a lot of things when you're sick that can really create a problem. And we see that a lot. People get the flu, they get dehydrated, their blood sugars are high, and they can get really out of control. More out of control than you've ever been when you're sick. It can be a real problem. Not taking enough medicine. Steroids is another thing. Long-term use of steroids can cause higher sugars. So if you are going on steroids, if you've been on steroids, a lot of times it'll make your blood sugars higher. Once you're tapered off, then usually the blood sugars will come back down. But know that steroids can do that. Develop a treatment plan with your doctor. Stay hydrated. Check your blood sugars more often so you know what they are when you're sick and not guessing. You might need to do some diet changes so you still get carbohydrates, whether they're liquid form or not, but they will provide you energy. Make sure you talk to your doctor about whether you need a medication change when you're sick, okay? Illness, we talked about, even minor colds, a fever. Could be a fever of 101. It's not real high, but you can still get higher sugars with this. Develop a sick plan. What happened? What do you do? Drink plenty of fluids. Take your diabetes medicines. Do you take them or not take them? If you're not sure, call your doctor. Okay, they need to know what your blood sugars are. All right? Usually if they're under 180, the doctor will say, okay, go ahead and continue taking. But as you start to get lower, they may not be the best thing to do. Okay? This is really good for diet and exercise to improve control. If you go long periods between meals, you can actually get higher sugars. So by restricting carbohydrates and waiting to eat. So if you eat more regular meals every 4 to 5 hours, your balance usually is better. If you're following the meal plan and eating regular meals and not going 6, 7 hours between meals, you usually overeat when you finally do eat, and then it doesn't work in your favor. Exercise regularly. If you're not doing any exercise, try a 10-minute walk. Start somewhere. Your food, non-starchy vegetables. This is the plate method that we use this. This is how your plate should be organized when you're eating. Half of the plate, non-starchy vegetables. They don't have carbohydrate because they don't have starch or sugar. Protein, 1/4 of the plate, and 1/4 of the plate is your starch or sugar. Okay, not a half like most people. The carbohydrates are 1/4 of the plate. It's a good way to think about how to organize what you eat. Am I eating too big of portions of carbohydrate? See that plate? Looks pretty good. It's got a fruit. That's carbohydrate. It's got a little bit of bread and noodles. It's got fish. It's got salad. And it's got avocado for fat. Not too bad. Okay? Not too bad. Carbohydrate foods, starches are your breads, your rice, your cereals, your potatoes, your pasta, your fruits, any fruit. They all have carbohydrate. Milk, yogurt, cottage cheese, carbohydrate because they have milk sugar in them. Okay? And all sweets, right? Those are carbohydrates too, because they're made with sugar and they're made with flour. Lots of carbohydrate. You digest them, and those things go into the bloodstream, and you get the glucose goes in there into your bloodstream. And if you have too much, it's too hard for your pancreas, along with your medicines, to bring the sugar down. Limit your salt. limit canned foods. I'm going to let you read through this. Cured foods, processed foods. All right, and there's a couple of things in the back I stuck in there about fats, different kinds of fats. What are the better fats? I get asked this all the time. What are the fats that you should avoid? Okay. And cholesterol. And there is a picture of a food label in here and how to read a food label. I think we're going to have a dietitian. We're going to be talking more later on. Next topic next month, I believe it's the dietitian going to be talking. I have to look. And she's going to be talking about beginnings of how to recognize carbohydrates and know what a normal portion is of 15 grams. So you know how many grams most women would need and how many grams most men would need. So you can determine whether you are going over or not. Okay? So this is the end of our talk. If you have questions and wish to stay, I will go around just for a couple of minutes.
What about HDL? How do you keep it above? The other figures are fine, like the LELs, and the HDL has been fine for a while. Cholesterol is not really a problem, but the HDLs keep slipping lower.
Yeah, the reason for HDL being low is usually genetic. So when people have a HDL below 30, and if you look at the studies which have been done on low HDL, about 10% of people have severe heart disease with that, coronary artery disease. So that's something very serious. So the best way of bringing up HDL, as Sandy pointed out, it should be above 50. So number one is exercise. As we exercise more, it increases HDL production by the liver. Number one. Number two is omega-3 fatty acid. It's well known and it's scientifically proven that 1 gram or more than 1 gram twice a day. It shouldn't be taken at the same time. It should be 1 gram twice a day after a meal. Breakfast and dinner does a really good job in trying to bring it up. The increase is anywhere from 2 to 10%, which is excellent. The third way of bringing it up is there are 2 medications which do a really good job. These are prescription medications. One of the general, I'm just going to give the general class. It's called Fibrate, Fibrate. So there are 3 different medications, well, actually there are 5 now. 5 different medications in this class, and they all bring up the HDL. The second class, which is a prescription drug and non-prescription also, is niacin. Niacin in high doses will bring up HDL. So these are the 4 ways of doing it. There was an experimental study done on intravenous HDL, but that's food for thought down the pipeline, not right now.
I experience numbness in my hands after I've had high activity for several hours. I don't know. And I've had the same thing in my feet if I've walked, say, over 7 miles at a time. I've noticed some numbness.
Yeah, the usual reasons why a person develops numbness in their extremities, whether it's hand or feet, it's either one of 2 things. One is it's circulation. So if there's a decrease in circulation, it will produce numbness or can produce numbness. The second reason is nerve involvement. So if you have nerve involvement, it'll do the same thing. So the best thing to do is when you visit your doctor, the doctor can check for both circulation, which is supply of blood with the blood vessels. The second is nerve function. And for example, one of the most important things to check whenever this happens is a vitamin B12 level. So there's a way of testing it out, and I would request you to make sure your doctor does that.
The last time I saw the doctor, he did check my feet for sensitivity.
That's the monofilament test.
And he said I was all right. So
Yeah.
I had told him about this, and that was what he tried
Right.
on my feet.
You bring up a very good point. There's a difference in testing with monofilament and testing for something more than that. So what we have been concentrating on is diabetes and its effect on nerves. Okay. So what happens is this. Okay. So diabetes is a disease of blood vessels. I want everybody to make sure we understand that. So it's like the mother of all inventions, the mother of all complications in diabetes is a change in the blood vessel wall. Because of higher levels of blood sugar, it changes the character of the wall. So if the wall should be looking, let's say, gray, it becomes black. Okay. And what happens with that is, if it happens in the eye, it causes eye damage, as Sandy presented. If it happens in the heart, it causes a heart attack. If it happens in the brain, it causes a stroke. It happens in the kidney blood vessels. These are blood vessels which are being affected. It causes kidney damage, kidney dysfunction. And if it affects the nerve in the legs, it's going to cause nerve damage. And the earliest manifestation of nerve damage in the feet, more than the hands, is the loss of sensitivity to the pressure from a monofilament. That's the critical area here. So if that is normal, what that means is the diabetes has not affected your or anybody else's feet and the nerve in there to cause dysfunction. However, if a person continues to have numbness or tingling, there are other reasons for that, and a monofilament test will not prove that. So it needs further workup. That's the answer.